Thank you for joining us for Conversations in HIV, Patient Voices Guiding Physician Choices. During this segment, we will be discussing my patient. He's an older man with HIV with extensive ART resistance. I'm Paul Sachs, Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. And I'm joined by my colleagues, Dr. Christine Erlandson and Dr. Jordan Lake. Welcome.
Thank you.
So this is a man who learned about his diagnosis 30 years ago, and let's hear him tell his story.
Well, learning I was positive, I started to get lesions, sarcoma lesions, like near my feet and ankles. I felt fine in all other aspects. I had no idea. I tested positive in '94, and more than positive, I believe my T cells were about 200-ish. So was I surprised? Yes, I was a little bit surprised for several reasons. That one, I didn't feel sick, and two, I really was pretty regimented about safe sex. But, somewhere along the line, I slipped.
Did you have any hesitancy about starting treatment, or were you always very enthusiastic about it?
I did it enthusiastically, thinking, let's do whatever we can to help. Like I probably had 3 or 4 medications. Mm-hmm. But what seemed to be the case was they would work for 2 or 3 years maybe, and then start to fail, or you maybe develop resistance to them.
So let me tell you about this case, because it was one that was really both very upsetting and ultimately very rewarding for a variety of reasons. So this is a 60-year-old man, and he was admitted with terrible diarrhea, weight loss, and skin lesions. And I had known him for years because I was seeing him regularly for what I thought was stable HIV. So I had last seen him 4 years before this admission to the hospital. At the time, he was working full-time, selling furniture. He had virologic suppression on a complex regimen that basically was common for people with a lot of resistance. He was on raltegravir twice a day, darunavir twice a day, and tenofovir FTC, and really was taking his medicines without side effects and pretty faithfully, refilling them on time. And my note goes, overall stable from the HIV perspective, despite a history of multi-drug resistance. Maybe I'll switch the dolutegravir to dolutegravir from raltegravir. And the other thing about him is that he had a lot of background, problems. As you heard, he had Kaposi sarcoma. He also had metastatic anal cancer. That both of those were in remission. And his CD4 data was pretty low. So let's hear what happened next. And this leads us to a kind of tricky part of the discussion because the pandemic hit, and then you and I lost touch for a while.
Within the HIV people who had been HIV positive but undetectable for 20 or more years, there started to be a little bit of a talk and a movement towards maybe you could not take your medications, and that after that long a time, your body was fighting the virus on its own or whatever. But I had several friends who were saying, are you thinking about this? And nobody was badgering me or anything, but I guess I thought, all right, I'll try it. It wasn't a quick decision. This was maybe a good year or more of them just mentioning it to me, and the really fault at my end was to do it without your supervision or letting you know.
So, you probably have similar patients who decide that they want to stop therapy. You want to share any of your anecdotal experience or the reasons, Christine?
Yeah, I was thinking of a patient I have that was very similar circumstance, but she's from a country in Africa, mm-hmm. and there's this sense of when you go back, the healers there can get your HIV to go away with the holy water. Mm-hmm. And so every time she goes back to visit family, she comes back off of her antiretroviral therapy, thinking that the holy water cured it, until unfortunately her viral load rapidly rebounds again. And so it's so hard to you want to support the patient in their decisions, but then you also want to avoid consequences like what we see with your patient.
Yeah. Jordan?
Same thing, hearing the story made me think of a lot of my patients. And it's so hard because, he was talking to the fact that he's a long-term survivor. He's been on treatment for many years. Treatment fatigue is normal mm-hmm. at some point. And we know both from intentional and unintentional treatment interruptions, that some people can stop their medicine and not have CD4 decline for quite a long time, not have viral rebound for some period of time, but others decline very quickly, and you never know which side you're going to be on.
Yeah, and you never know when it's going to happen.
Yeah.
You know, one thing that struck me about this case was how poorly I had pre-identified him as someone who would stop treatment. As you can gather, you know, he's got good medical literacy. He kind of, you know, bought into treatment very readily when he was first diagnosed. So it really surprised me. Let's hear what he has to say.
I stopped taking my medications and was seeing how things went. I think for a year, not any problem. So maybe a year and a half into it, I started, I would get sick for a couple of days and then I'd be fine. And then now I was getting sick 3 times in the month, but just for a couple of days, go away and I'd feel fine again. And then one morning I was getting out of the shower and when I pulled the shower curtain back, I looked right in the mirror and I looked like Skeletor. And then, you know, I really started being sick and being in bed a lot. And I called my very good friend. I said, come over, I'm calling the ambulance. Will you help me get ready to go to the hospital? When I got to the hospital, I told the person that I was pretty certain I was suffering from wasting from AIDS and that could he please let Dr. Sachs know that I was here. You showed up within the hour or certainly 2 hours or whatever and saved my life.
So he basically made a decision. This is, you know, the kind of decisions that we can't always control. He had heard from his friends that his medications may not be necessary, and this is around, you know, the pandemic had hit, and he was becoming more socially isolated, and he then suddenly started to get really bad weight loss, really bad diarrhea, and eventually he went from functioning fine without taking ART to being unable to walk. So when he got admitted, I have to admit, I practically didn't recognize him. He was incredibly cachectic appearing. His weight was down 30 kilograms from his baseline of 75. He had all kinds of lesions, obviously were KS lesions, purple lesions on his neck and his limbs, on his body, on his penis, terrible oral thrush, and a sacral decubitus ulcer, which shows just how incapacitated he became. So you as infectious disease consultants, as HIV specialists, would sometimes get consulted on a case like this. What would be going through your mind?
I mean, looking at that clinical picture, my first assumption is that the person is not taking their HIV medications, and that, you know, that is the solution to a lot of the problems. Yeah. But then you have to have the conversation about why they're not taking them. Are they ready to restart? Do we need a different regimen? Mm-hmm. These things all start playing in. And then, of course, you know, if you identify any comorbidities or opportunistic infections that need treatment at the moment, you'll do that. But the bigger conversation is how to get this person healthy again.
Yep. And excellent. And Christine is the you know, one thing that we often get asked about by our medical teams when they're admitting a patient like this is, should we resume antivirals now, or should we like do the workup first to see what acutely is wrong with him? Do you have any thoughts about that?
Yeah, I mean, if he stopped his medications fairly abruptly and we don't have concern for new resistance, then unless we have concern for CNS infection or something like that, I think it's probably worth trying to get him back on medications as soon as possible.
Totally. I
mean, he's a good example of there's probably multiple diagnoses here. And I think when we see a patient with advanced HIV, it's never one single infection or one single comorbidity or one single opportunistic infection. Oftentimes we're looking for multiple different things that are contributing to the symptoms they're coming in with.
Yeah,
exactly.
So
I think it's start your big workup and don't limit yourself to one diagnosis.
Totally agree with that approach. One thing I actually try to teach my fellows is to go back and look at the old resistance tests. Anyway, he did get this very extensive workup, not surprisingly, because he was so sick. He had a CT scan of his whole body, and he did have evidence of an inflammatory pneumonitis, and then also some opacities in his liver and spleen that could have been metastatic disease from his 2 cancers. We really didn't know what they were. He was started empirically on treatment for community-acquired pneumonia, was given fluconazole for thrush and atovaquone for pneumocystis prophylaxis, and then his beta-glucan came back at greater than 500. As we know now, infectious disease, that's a very strong suggestive study for pneumocystis pneumonia. Anyway, I will say there was additional diagnoses were made. His stool studies were positive for Giardia. His stool culture was positive for Shigella. It was a Shigella that had a resistance pattern that we commonly see now. And so he got admitted, of course, to the hospital and was treated with the medicines I mentioned. I want to say that the admission was not a straightforward one. He had diarrhea that lasted much longer than the first couple of days of the hospitalization. He had a retinal exam, which didn't show any CMV retinitis, but he did have CMV reactivation detected in his blood. He couldn't give us a sputum sample to confirm the diagnosis of pneumocystis. So just wondering, Jordan, would you have treated him empirically for pneumocystis?
Yeah, that's a hard one. It seems that sometimes too many people get treated for pneumocystis empirically, but here at least you have a lab test guiding you, and you have a pneumonia pattern, and so it's not. He doesn't just have thrush. He has other things going on, and while you're working him up, because he is so sick, I think it's reasonable to start treatment empirically.
Yeah, I've got to tell you, I was a real devotee of this beta-glucan test, which I know all of people in infectious disease around the country now who are listening to this are going to be mad at me because there are so many false positives. But we did learn, at least from one of the ACDG studies, which was the timing of opportunistic infections, that people who with advanced HIV disease and a beta-glucan greater than 500, they almost always have pneumocystis. So we had, wasting syndrome, Kaposi's, pneumocystis, CMV colitis, I should say. His endoscopy showed that he had CMV inclusion forms, Giardia and Shigella. And, getting back to what you said before, Christine, even though there's Occam's razor, which is basically that there's one simple explanation for all cases, there's also, Hickham's dictum, which basically says a patient can have as many diseases as they damn well please, which is certainly the case here. So now, he's not been on ART for 4 years, right? This hospitalization, his CD4 cell count came back at 50, which is the lowest it had ever been. His viral load is 100,000. We went back and found his 2006 resistance report, and you could see, he has 3-class resistance with multiple mutations in the nucleosides, non-nucleosides, and PIs. And so, what antiviral regimen should we put him on? I mean, I know that that's an impossible question, but if you were to just include one drug class in his new regimen, which one would be the clear choice?
Well, I guess the first question is, does he need a new regimen? If his old regimen was working and he was suppressed on it, then is it worth just starting him back on something that he was taking successfully previously and getting a little bit more into the reasons he stopped? Were there side effects that led him to stop that regimen, or was it really just I want to stop it because I'm done with medications? And so in the acute setting, would you have just started him back on his old regimen?
Well, he was taking raltegravir twice a day.
But probably don't need that one.
Yeah, exactly.
Yeah.
So
at least dolutegravir instead of raltegravir.
Exactly. And I think that we now have these data from studies of treatment failure. The Nadia trial is, of course, the sort of pivotal one that show that even people with extensive nucleoside resistance, most of them can achieve virologic suppression with 2 nucleosides, tenofovir, FTC, plus dolutegravir. The same would be true for the protease inhibitor. Now, granted, the Nadia trial did not include patients this sick or this complicated. There have been subsequent studies that show something similar, which is the DEFT trial. And the DEFT trial looked at the same treatment failure population, again done in sub-Saharan Africa, where it actually also done in India, where it basically found that the dolutegravir approach was superior to the boosted PI approach. So the last one I'm going to mention is Vizend, which I don't think has been published yet, but this also showed that the dolutegravir approach for people with treatment failure was the way to go. So we ended up repeating his genotype And you know, when we saw this result, it was kind of amazing. He had very, very little resistance detected. You know, he had some low-level nucleoside resistance. He had full susceptibility to the non-nucleoside class before he was pan-resistant. And the protease inhibitor mutations are all gone. Jordan, how do you explain this?
Well, he's been off ART for so long now.
4 years.
That I'm not that surprised he's reverted to wild-type virus, essentially, with the NRTI caveats here. But that doesn't mean you don't need to worry about the things that you've seen in the past.
Yeah.
Did you think about doing an archive?
So he was actually, we didn't have to do an archive because he was viremic.
Yeah.
Yeah,
Just
so-
to see if there were old resistance patterns that could
you know,
be detected,
actually,
or no?
I have not
Okay.
ever sent a proviral DNA resistance test in someone who has viremia.
Yeah.
Yeah, kind of interesting thought. So anyway, he ended up getting treated for all of his various infections. So this is, you know, there were a lot of them. Pneumocystis, Shigella, Giardia, oral and esophageal candidiasis, C. and V. colitis. One of the really challenging parts was whether to treat his Kaposi sarcoma with chemotherapy. And I don't know whether you ever have engaged with your oncologists on this issue. You know, we don't see as much Kaposi sarcoma as we used to, but when you have this discussion with your oncologists and the person's not on ART, what do they typically tell you?
We haven't had a lot of this recently, but I would say if it was skin localized, that it would probably be a start ART, take some of these other medications first, and then let's see where things are.
Yeah.
But
Jordan, has that been your experience?
I've seen it more, you know, case-by-case basis. Definitely skin limited. They will often, you know, hold chemotherapy, but even sometimes I've seen people that I found to be continued on chemo way longer than I thought that they would have once they immune reconstituted, or similarly, certain oncologists feeling safe delaying chemotherapy when there was a hint of visceral KS. And maybe I felt uncomfortable with delaying chemotherapy, but that's why we have our colleagues to rely on.
One thing that's really difficult is when you get an iris-like response when you resume ART, where the lesions get more inflamed and you don't know whether they're going to progress from that point. And then there's also this rare patients who, despite immune reconstitution with ART, they still have progression of KS. That is very uncommon, but it does happen, and those are really challenging cases, and they do require chemotherapy. So he went on a regimen of bictegravir TAF plus doravirine initially, and because he had no more NNRTI resistance, we thought, and plus if we looked back at the mutations he had historically, he would have had full susceptibility to doravirine. You know, doravirine selects for somewhat different mutations than the older NNRTIs. So with K103N, doravirine's fully active. And actually that's true with Y181C as well. So he went on doravirine plus bictegravir TAF. Virologic suppression was eventually achieved. He had a very long hospitalization. He was in the hospital for nearly 2 months. And then he went back to eventually his baseline weight. You know, it's remarkable. His weight rebounded to nearly 75 kilograms. We have stopped the doravirine, and he still has maintained virologic suppression, and his skin lesions have practically vanished away. So any other questions?
I think it's fantastic he's on a one pill once a day option after all of that resistance, and that's probably something he's more likely to stick with over time.
Sure.
Same. We're back in the success field.
Yeah.
Oh, yeah.
Area.
No, I mean, I think cases like this are kind of a reminder of how miraculous our treatment is. Both the fact that he was diagnosed with AIDS and KS in 1994 and was still doing well, you know, all these years later, and then to stop treatment and go through such a difficult phase and then to be able to resume therapy. It was very gratifying. which is why I wanted to share it.
Yeah, it's a nice success story. I think it does make you wonder how much of these old resistance patients that are on multiple different therapies, how much could we condense them to a single tablet regimen with success? And I'm always a little nervous changing people.
I've become less nervous, and the reason I'm less nervous is because of some of the studies that I mentioned, and then especially the people who are suppressed on the with a lot of historical resistance, because there are several different studies that show that they can easily be switched or safely be switched. So thank you again for joining us for this segment. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios that we will be discussing. Thank you.